It is 1 minute past the hour, so we might get started. I know that we always have a very packed agenda to get through everything on time. Before I start today, I would like to acknowledge the traditional owners of the land on which we live and work and pay my respects to their elders past, present and emerging. I'd also like to particularly welcome all of our attendees from Melbourne this morning. I know that particularly for patients, that this is an incredibly stressful time for some. And certainly at PVI, we see those struggles and hope that the next week brings some positive news. And this is just a brief disruption. Please take care and go gently with yourselves. If this is your first Patient Voice Initiative event, my name is Jessica Bean and I'm chairperson of PVI. I'm also a patient living with cystic fibrosis, and I passionately believe that the path to empowering patients to be involved in healthcare decision-making is capacity building and opportunities to learn. Today is our final webinar for this series, and we are going out with two brilliant speakers who will focus on health economics in the decision-making process. I've had it said to me before that it's unrealistic to expect patients to understand health economics. And I guess my response to that would be that we're not expecting or asking patients to become health economists, but we can involve them and their communities and learn from them in that process, just like we would involve many other types of experts. Because patients are experts in the lived experience of their disease. And for many of us, there isn't a day goes by that our lives are not impacted by health economics, both positively and otherwise. By empowering patients with knowledge in this area, it helps us understand what we know about our condition that might be valuable to health economists and the healthcare decision-making process. It supports us to speak in a way that gives us the most effective voice. The ability to bring these webinars to you today for free is thank you to our Patient Voice Initiative sponsors. We are much appreciative of this because we don't believe that opportunities to learn, the finances of that shouldn't be a barrier to patients and to the opportunities for them to learn. Before I hand over to our speakers, just a couple of housekeeping matters. We hope that you have lots of questions for our speakers today, so please add them to the chat as we go. Don't wait until the end because you might forget them. And our wonderful coordinator and Single will facilitate those at the end of both the sessions. As with most of our online events, they are open to everybody, but our priority really is supporting opportunities for learning within patient communities. So if you have a question and you are not a patient or patient group, please just make sure to pop your name or your company or organisation with the question that you're asking to help us prioritise those questions. Please keep your cameras off until the question time at the end. And with that, I would like to introduce our first speaker, Dr. Richard Abreu Lourenco, and I'm so sorry for that pronunciation, who is an associate professor with the Centre for Health Economics Research and Evaluation, or CHERI, at the University of Technology, Sydney. He is an experienced health economist with a keen interest in applied economic evaluations, patient preferences, and quality of life, and the economics of specialty health areas. Currently, he's the program lead for the Cancer Australia Cancer Research Economic Support Team and the senior evaluator for CHERI's PBAC evaluation group. Richard is an investigator on a number of cancer clinical studies and studies investigating preferences for healthcare decision-making. Anybody who has been or attended to our in-person workshops, remember those, you might recognise Richard's name from the very useful handout that we often share called Drug Reimbursement in Australia. And if you'd like to have a look at that, you can also find it in our resource library on our website. Welcome, Richard.
Thank you, Jessica. And it's a real pleasure to be here today and to be able to speak to everybody about something I'm very passionate about, which is building everyone's capacity about health economics. Like Jessica, I think this is something that's very important for everybody to know. And I really enjoy speaking to people like yourselves about it, telling you a little bit about what it is, how it's used, and importantly, how you can contribute to it in the process. And Sally's going to speak about that in much more detail than I. Here are my disclaimers. I won't go into those in great detail, except note the last one. So just briefly, one way to think about health economics and to think about what this is all about is to put yourself in the context of a decision maker and imagine that you're helping the government decide whether it should fund a vaccine that's still in development for COVID-19, something that's very topical at the moment. And you can think about some of the issues they might be grappling with. Ordinarily, I'd pose this to you in a live setting, but you can imagine that we might be thinking about, well, does it work? Is it effective? Importantly, is it safe? But we also want to think about things like how does it impact on people's quality of life? Does it prevent them from actually becoming sick with COVID and going into hospital and requiring lots of medications? And then what about the cost side? How are people going to access it? How much is it going to cost the country? What costs is it going to prevent in terms of people not being sick? All of these are aspects that decision makers in healthcare think about, and they're all things that they balance. And the types of agencies that think about those things are listed here in the table. The ones that you're probably most familiar with in Australia and New Zealand are PBAC and MSAC for Australia, so PBAC for drugs and vaccines, MSAC for medical services, devices, diagnostics, and PharmAC in New Zealand, which covers the gamut of drugs, vaccines, devices, and other therapeutics. And these agencies are charged with looking at whether we're getting value for money, and that's a very important concept in funding our healthcare. And in making those assessments for value for money, they rely very, very heavily on this notion or this theory of health economics. And health economics is just a branch of economics. It's not something that has been made up or something that's plucked out of the air. It does come and is heavily grounded in the theories of economics and has three really important key principles underlying it. One is that there are always choices that we're making. All of you have made a choice to be here and to allocate your time to be here and listening to us this morning. And in the same way, we make choices about where we allocate our scarce healthcare resources. We don't have an unlimited bucket of healthcare resources, so we have to decide where we're going to actually use those resources. When we do use resources, there are always consequences. That is, that some of those consequences are good. We make people better. We make people feel better. And some of those consequences are bad. You might have adverse effects associated with certain medications or certain treatments. And we need to be able to capture all of those consequences. And in health economics, we want to measure the good and the bad, not just the good. The other very important concept from a health economics perspective is that once we've used a resource in one way, it's not available for use in another way. So we're always looking at the comparative costs and outcomes. So it's all about comparing one drug, for example, with another drug. It's never about just how much something costs in and of itself. And this is this notion of opportunity cost. So you face this every day in your lives. Again, the opportunity cost of you sitting here and listening to me at the moment is that you might be off reading a book or taking a walk on the beach or just watching something on television. Sorry, people in Melbourne. Health economics applies all of these concepts to healthcare and to how we allocate resources in the healthcare system. It does that, and we approach healthcare slightly differently to how we approach other markets because health and the healthcare market is very different. So we normally think about markets operating very, very well. So markets for shoes, for example, or markets for telephones, they operate well because we can find lots of information about them and we know how to look at the quality of those products. And essentially, the number of people selling them and the number of people buying them will match so that the market will work. In healthcare, this doesn't work in that way because there are lots of things about healthcare that means that there are imbalances between the supply and the demand for healthcare. And you can see what we call the failings of the market when it comes to healthcare here on this slide. We're not sure when we're accessing healthcare about whether or not it's going to make us better. We don't know what the outcomes will be. We also often, and this is a bit of a failing of the system, we don't know how much it's going to cost to access healthcare or how much it's going to cost us in the longer term. There's also this notion of asymmetry of information. And what that means is that the people who provide healthcare know more about what's going to make us better than we do ourselves. So we put a lot of trust in those healthcare providers to do the right thing by us in providing the care that we need to make us feel better. The other notion about healthcare, and this is a very good one at the moment, is that my consumption of some healthcare might have beneficial, potentially negative impacts on other people. So if I choose to get vaccinated, that has a benefit for other people because me not getting sick means I have less chance of contracting a condition like COVID and giving it to others. Conversely, if I don't get vaccinated, then the risks to other people also increase. So we have this, what we call a positive externality when it comes to vaccines. All of those failings mean that if we left it up to the market system, the buyers and the sellers, to try and organize healthcare, it wouldn't work very well. And you end up with a system like the US, where you have large sections of the population, around 40%, who either have no access or very limited access to healthcare. And so in the Australian system, the government steps in to make sure that we do have access to healthcare, and it allocates healthcare resources using health technology assessment. And to make those allocations, it uses and relies on information from something called an economic evaluation. Now, economic evaluations help decision makers. They're not the only decision-making point. Be very clear on that. They help decision makers compare costs and outcomes of two approaches to the same problem. So let me give you an example. If someone has too much iron in their body, so they have a condition which means they accumulate too much iron in their body, they need to take medicine to reduce that iron. They might do that by taking an oral medication or having an infused therapy. So we can compare the cost and outcome of those two therapies and look at which one is producing and look at the additional outcomes that are produced compared with the additional costs. And we do that through a cost effectiveness analysis because we want to know, well, how much is it costing us for those extra outcomes that we are achieving? Is it value for money? The way that we do it is quite systematic, and you can see the steps here, and I won't go through them in detail, but I would point out that there are opportunities or points where consumers of healthcare can actually provide some input into these steps in terms of identifying, well, what is it that we're doing at the moment in practice? How are we actually treating patients at the moment? What are the things that patients need to do to access care? And that's an important point to understand when we're trying to assess costs, because we want to ensure that we're measuring all the right costs when we're doing these economic evaluations. We need to also understand what matters in terms of the outcomes, and we'll speak more a little bit about that later when we look at quality adjusted life years. So the type of evaluations that we can undertake really depends on how we look at these different outcomes. And there's two that we see quite often in applications to someone like the Pharmaceutical Benefits Advisory Committee, and I'll focus on those if I may. The first is where we assume that two interventions, two drugs, don't have any difference in the outcomes that they produce. And we're essentially looking at which one is the cheapest. So for example, if we have two statins that do exactly the same thing in affecting cholesterol levels, we just want to know, well, which one of those is the cheapest? And that's a cost minimization. The challenge there, of course, is defining what the same outcome actually means, because we could have two drugs that have the same impact on someone's clinical levels, like a statin, but if they're delivered in a different way, for example, or they have a different frequency of administration, you could argue that they're not actually doing the same thing. And we may want to look at whether that difference in how the patient experiences taking those drugs actually matters, and whether that should be captured in our value assessment. More commonly, what we see at PBAC are cost utility analyses. Now, these are very important analyses because we're measuring outcomes in terms of what's called the quality adjusted life year, which is the combination of how long someone lives by how well they live. And that's an important metric because it allows us to make comparisons across different conditions. And I'll show you that in a moment. In terms of the costs that go into these assessments, we are interested in as broad a notion of costs as possible. We want to ensure that we're capturing all the costs that are associated with patient care and include those in our assessment of cost effectiveness. Now, in some situations, this may mean that we take a broad societal perspective and we might wish to include things around patient costs for transportation and time spent to undergo treatment. That can be a little bit tricky to assess because we don't have systems set up to allow us to do that in a straightforward way, but it doesn't mean that it shouldn't be done. It just takes a little bit more work to do it, particularly in the context of a trial. And then in terms of how it's presented to decision makers. The outcome side of the evaluation is vital, and it's critical that this reflects the patient experience, both in terms of the clinical outcomes, but also the experience of how it makes patients feel and the quality of life aspects of what's happening, both in terms of the condition being treated and from the impact of the treatment itself on a patient's quality of life. So the quality adjusted life year, I think most of you will have heard that phrase, particularly if you've ever read an MSAC or a PBAC outcome document, is the combination of survival and quality of life during that survival. And the way we assess the quality is by asking patients typically to complete a questionnaire, usually in the context of a clinical trial. And here you can see a simple example of the what's called the EQ5D, and this is the 3-level questionnaire. Patients would complete this in the context of a clinical trial, and then the scores that are derived, or the scores that come from the patient, so patient ratings of quality of life, are converted to preference-based utility values, which is a societal measure or societal preference around living in those conditions. So we ask patients what it's like to have the condition, and then society rates those quality of life assessments. And the reason we use a society valuation is because we're applying these values to make resource allocation decisions at the public level, so at the societal level. That the combination of costs and outcomes is then put together in something called the incremental cost effectiveness ratio, which is just looking at this comparative difference between costs and outcomes to give us a ratio which we express as something like $40,000 per quali, to give us a notion of what is good value. The HTA bodies will then make an assessment of whether something represents good value or not. Now, in Australia, we don't have an explicit threshold or determined value of what represents cost effectiveness or what is value for money. And the committees will make that assessment on a case-by-case basis and not have a set threshold. Other bodies like NICE have an explicit threshold, 20 to 30,000 pounds per quali, and that raises a range of issues around what we might want to do in the market. And there are some questions posed there that you might like to think about. And indeed, I have a paper that has explored, no, I didn't write it, sorry, I should clarify. I can send people a paper which explores the implications of these two different systems and what impact it has on the cost effectiveness ratios that are presented to the HTA authorities. So if I can briefly just touch on how this is all used by the PBAC. So PBAC is the Pharmaceutical Benefits Advisory Committee. As most of you may know, they advise the Minister for Health on drugs to be listed on the PBS. They don't actually list the drugs themselves, but they advise the Minister on whether a drug can be listed or not. And in making those, and in providing that advice, one of their key inputs they consider is cost effectiveness. You'll note there that I said one of the key inputs they consider, and that's because it's not the only thing they consider. They consider a range of other factors, as you'll see here, including whether or not they have confidence in the clinical and cost effectiveness data, so how strong are the data. They'll make an assessment about the affordability of a particular product if it wasn't funded by the PBS. They'll look at whether or not the results are uncertain, so particularly if they have come from an early phase trial. They'll consider whether or not there are equity of access issues posed by making the medicine available or not providing the medicine. And they'll consider issues of medical need and whether or not it's potentially possible to identify who's going to benefit the most. Now, the latter is becoming more and more important, particularly as we develop a greater understanding about genomic medicine and our capacity to identify gene markers in patients and individuals that indicate they may or may not respond to particular medicines. Where the data for PBAC submissions come from, and these are typically submissions that are submitted that are lodged by the manufacturers of drugs, but not always. It's important to note that any group can lodge an application to PBAC, and indeed there have been community-based submissions, but it's usually the submissions come from the manufacturers of the drug. But the evidence that goes into these submissions will typically come from clinical trials, and there is a preference for the highest level of evidence. So that's evidence that's come from randomized controlled trials. And they want those data to basically reflect the area for which the company is seeking to have the drug listed. So they want to make sure that the data that are presented reflect where the company wants to have a drug used. Sometimes evidence is submitted from surveys and observational studies. And while these are of a lower order in the hierarchy of evidence, this is perfectly reasonable and may fill a very important gap that we need to understand in the evidence base. And this is, again, another touch point, and it's an area that I've had input to in the past, where information from patients and community groups can be very important, particularly where it's used to provide information about quality of life and how that can be used to weight survival as an input to an economic evaluation. And as I say, that can be a particularly important and strong input, particularly where quality of life hasn't been measured in a clinical trial. So we have this mismatch, as I said right at the start, between what a healthcare provider and what a patient might understand about their condition, but we also have a mismatch between patients and healthcare funders about a particular condition. And Sally's going to go into this in much more detail, but there is really a role for patient and consumer groups in advocating and in educating people like PBAC and MSAC about what it's like to have a particular condition and putting this information that comes in these submissions in context so that they understand what it's like to have a condition and what it's like to have a condition treated, so that when PBAC and MSAC are assessing these value for money propositions, they know, well, yes, this stacks up, or no, it doesn't. And that the information that's presented potentially better reflects the preferences of those who are not only those who are paying for it, but also those who are being directly affected by the conditions and the treatments that are being paid. Here are some ways in which consumers can input to economic evaluations. If you're in a clinical trial, there are ways to give consent to actually collect information for costs and in participating in completing diaries, which can be very important for some types of information, like travel, for example, like time away from work. And early on in the development of these clinical trials, there's a role in helping people like myself understand, well, what should you be asking? What are the right questions to ask? What information do you need to be collecting? Are you collecting it in the right way? And I think they're important things to understand. At At the other end of the spectrum, and I'm a strong advocate of this, is to make sure that your voice as patients and consumers is placed on understanding the results that come out of this sort of research. Because all too often, people ask patients and consumers at the beginning for their input in formulating these sorts of things, and then don't ask them for their help at the end in trying to interpret the results. And I think that can be a really critical input. I think I'm getting the wind up here. So we need to think about those things and recognize that there is a very strong role for groups like yours in helping researchers like me not only formulate this sort of research, but communicate the research, and then also to help HTA bodies like PBAC and MSAC to put that evidence into context so that they can use that in their decision-making process. I'll leave you with those takeaways, and I will stop so that Sally can go on to her section.
Thank you so much, Richard. I think we could have listened to you for much longer, but unfortunately these sessions are short, so people can fit them into their day. I think you agree that Richard has a real talent for explaining some of these very technical concepts in a clear and relatable way, which is so important for us as patients and patient communities. Just a reminder that we'll be taking some questions at the end, so please pop them in the chat box as we go. And I would love to introduce our second speaker, Dr. Sally Wertley. Sally has a PhD in the field of health economics, health technology and decision making. She is currently the lead for the Consumer Evidence and Engagement Unit within the Office of Health Technology Assessment. And many of you will know Sally as the person who can offer really useful, specific advice when you're preparing consumer input for PBAC or MSAC. She also generously collaborates with us to plan these webinars. And beyond all of this, Sally also maintains an honorary research fellow position at the School of Public Health at the University of Sydney. She started her career in the disability services sector before becoming an evaluator of health technologies, both in Australia for the Medical Services Advisory Committee and in the UK for the National Institute of Health and Care Excellence. She has been an active member of the HTA International Patient Citizen Involvement Interest Group for many years and has a particular interest in how perspectives and preferences of patients and the wider public are considered in health policy and decision making. Thank you so much for joining us, Sally.
Thank you, Jessica. And I'll attempt to share my screen now. Can everyone see that? Is that okay, Jessica?
That's great.
Yep, all good.
And I may need to turn my camera off at one point if I break up. So do let me know because my internet's a little bit unstable today. So I just want to say, firstly, at the outset, thank you to PVI and to Jessica for the introduction and for the opportunity to speak today. It is a topic that I'm quite passionate about. And like Richard said, it's great to be able to share with the audience today. Thank you also, Richard. Always an engaging presentation about health economics. I guess at the outset, I'd like to say while I am the lead of the Consumer Evidence and Engagement Unit at the Department of Health, the views that I'm going to present today don't necessarily represent the views of the Department of Health more broadly as a large organisation. And just to give you a little bit of context for those people who don't know about the Consumer Evidence Engagement Unit and where it's located. So basically it was established in 2019. It sits within the Health Resourcing Group within the Department of Health. So, and then under that is the Technology Assessment and Access Division and the Office of Health Technology Assessment. So the part of the Office of Health Technology Assessment, or the Office of HTA, where we're located, brings together the assessment and support functions that deal with the Pharmaceutical Benefits Advisory Committee, the Medical Services Advisory Committee, and the Prosthesis List Advisory Committee, which look at various technologies to do with reimbursement. So there's three main areas that the unit focuses on. And this is to do with supporting individual consumers and consumer organisations who are putting input into these various different processes, as well as supporting consumer committee members who are across the various committees, and providing support into internal processes to the Department of Health and the Office of Health Technology Assessment. So as Richard said, and said, health economics is quite complex, and I've got here, it's not just about costs, because I tend to think there's a misconception sometimes that when we talk about health economics or cost effectiveness, we're talking about costs. And for those who are wondering why there's a loaf of bread, or tuned in last week, I think when Joe Watson had talked about Bunnings sausages, I'm sort of continuing this theme here. So the loaf of bread is meant to represent that. If I was thinking of a sandwich, costs are just one component. So bread would only be one component in a sandwich, but there are other things that we need to consider what makes a sandwich. There are fillings to go in, and that will depend on what we might have in our cupboard, our preferences, how hungry we're at a time, and we all have different perspectives of what makes a good sandwich. So it's a little like health economics. We have different perspectives about value. We have different methods and tools to measure value, and some of this will all be influenced by the data that we've already collected. But there has been, and this is wonderful, that we have seen over the years that there's agreement that patient and consumer input is vital into these processes. So thinking more broadly about how we can, the system in general, as Richard said, we're really looking at the new treatment versus what's currently available. And this is an important point because it really distinguishes it from some of the decisions that you would make at a regulation level. So thinking about the Therapeutic Goods Administration, they're not looking at current treatments or comparing things in the same manner. So in reimbursement, we're really looking at one treatment versus another one, what's currently available. And the costs, we're looking at the cost of treatment and health systems costs. And as Richard pointed out, there's also the issue of broader societal costs. And that's maybe something we can talk about in the discussion. And when we're talking about benefits, there's always a combination of advantages and disadvantages. So ideally, when we're thinking about the balance between a new treatment and a current treatment, we're hoping that the evidence or the data is going to come from clinical trials. And these are going to be good quality clinical trials that have measured the outcomes that are important to patients, that they've been done over a period of time, that they have good follow-up, and that they have captured some of these costs. We know that there have been improvements in clinical trials over the years, but certainly there are more improvements being made. So when we don't have this data from clinical trials, we need to look at other forms of evidence. That might be real world evidence or other types of surveys, but it has to be of good quality. And then we find if we don't have this data, we have to make assumptions. So the question really is, how can consumers add value into this model, and where is their evidence that they're bringing towards? So on this slide, I've listed some of the questions that we are interested in from the consumer perspective. And you can see that they're quite specific. So if we're looking at the new treatment, we might ask people, what changes to your health costs would you expect to see from the use of this medicine? Or if people have used the medicine, what changes in health costs have you experienced? Or what are the main costs associated with your health condition currently? So if people can give that specific type of information. So being quite specific about these experiences and costs really helps think about how this information can be integrated into a health economics model, and also to help the committee who might be deliberating see that it's what type of evidence consumers can bring into these processes. Importantly, all of this is framed in terms of the population that's being proposed. So if you think about it, for example, the costs and benefits are going to be influenced by how old the person might be, the severity of the condition. So it's very important to understand the population, because you can see how we're collecting that, or how we're considering these benefits and costs are going to be framed by the overall population. In the Australian system, the population will be proposed by the applicant, and it will most likely reflect a clinical trial population. So it will reflect the evidence that's already been collected. So it's quite important, you can see that at the start, to get the evidence that we want in the population that we want in the outcomes that are important to patients. So in Australia, there are some differences between the processes supporting the Medical Services Advisory Committee, MSAC, and the Pharmaceutical Benefits Advisory Committee. So in the MSAC process, consumers can comment on the proposed population before the report has started. So they have a greater influence at the beginning of the process, whereas at PBAC, it is a little bit later. However, it's important to note that all comments received are read and considered in terms of the evidence that's presented by the applicant, and the committee will see the comments and consider these. And it's not so much the number of comments, but the quality. So again, going to this idea of providing specific information around the costs and benefits. So for people who might be interested, for an average PBAC meeting, there would be around 500 comments we would receive across the agenda items, but this can range significantly. So how can consumer input make a difference? Well, one way is that it can confirm what has already been presented in the report, and it provides reassurance that all the relevant benefits and costs for the new and current treatment have been captured for the population proposed. So it's confirming what we've already seen in the submission. But in other cases, particularly for new treatments that are more expensive, where we might just see a small change in benefits over what's currently available. And it might be small in terms of numerically, when Richard was talking about quality adjusted life years, on paper, it might look quite small, but for patients, it might not be a small change at all. So in these cases, consumer input can add colour to the inputs and change the way the benefits are presented and how we might think about these benefits. And last week, in the seminar on uncertainties that was run by Patient Voice Initiative, I think Nicole Millis from Rare Voices Australia, a great example of a medicine that children were taking. And while they had a 6-minute walk test of looking at functional ability, and there might not have been a huge difference, this actually translated to the children and the families as being quite significant in their lives. We got to see the children were able to play with friends at school or were able to visit grandparents. So it's this context, it's this extra colour that perhaps is not always captured in clinical trials that is really important to get from consumer input and can make a difference and add to this health economics model. So another way is that consumer input can add value can add another factor that perhaps was not considered. We talk about clinical trials, for example, and we know that in some cases, outcomes that are important to patients haven't been captured. So if there are outcomes that are more important to patients and they bring this in the decision-making and in the model, it will reflect how we're thinking about the benefits and the costs. Or there could be things that are not captured again around side effects from current treatments. For example, people might be going to their GP more frequently to manage symptoms that aren't controlled by current treatments that aren't necessarily captured in the data that we already have. Consumer input can also fill gaps in current treatments or benefits. So as we were talking before, data is not always perfect into the models, and sometimes assumptions need to be made, and the assumptions rely on advice. So consumer input can add valuable advice into these areas, particularly for health conditions that may be uncommon or have a more complex pathway that is not so well understood. Lastly, consumer input may indicate that we need to consider a completely different population. So the population that is being proposed by the sponsor in some cases might be appropriate, but there might be another group that also have a particular unmet need that need to be considered when we're thinking about it in reimbursement. For example, if we're thinking about younger children versus of older adults, or thinking about severity of disease. So in these cases, consumers can suggest a different population, which will need to reframe the whole way we're thinking about the costs and benefits and the health economics. So consumer input can also assist in thinking about the financial impact. So how many people are likely to use a new treatment? This is really important because there are assumptions often if we're thinking about submissions about how many people are going to use a treatment. And we know from looking at analyses of health technologies that have been reimbursed, that sometimes there's other reasons why a particular technology might have more usage or lower usage than we had expected. And consumer input can provide valuable insights in relation to this. There might be particular reasons why one treatment might be preferred over another, or the circumstances. For example, as Richard had mentioned, just the way it is administered. One might be an oral medication versus having an IV or where or how it's administered. So these are important factors to consider as well and can be really valuable. So lastly, the key messages I really want people to think about is that consumer input is a valuable source of information that can add value to the health economic model or committee deliberations when considering cost effectiveness. Sometimes it might just confirm what has already been presented, but it's important that it be quite specific. That is where it's most helpful and can be integrated into a health economic model or a deliberation rather than the broad statements. So the more detail and specifics that people can provide is ultimately very helpful. And sometimes, regardless of the quality of this input, there will be other factors that can only be addressed by the applicant in these processes. There might be and so that's why there may be some delays in some of these processes, but thinking that the quality of the consumer input has not in any way influenced this. So I'm just going to stop there.
Thank you so much, Sally and Richard. Such an interesting session, and as we went through there, I was reminded that, you know, last week we recognized how uncertainties is a term that means something a little bit different to patients. Their uncertainties are not the same as HTA's uncertainties. Assumptions are a different thing for a scientist than to a patient, and then today we talked a bit about we could see in the comments about opportunity cost. And opportunity cost may feel like something different from the patient perspective compared to the health economics perspective. And I thought it would be interesting to ask you both more about broader societal costs, because I could see that Nick had a question there about the cost of not funding. Is it considered the cost of not funding a treatment? And what's the opportunity cost for patients when treatments aren't funded? Is that taken account of in health economics?
Do you want me to answer that one, Sally?
Please do.
Or we both can. We both can. So, I mean, and that's really interesting question, Nick and Anne, about whether we look at that in terms of what essentially really is an opportunity lost. So, in what goes to the committees, that it isn't enumerated in that way, because what we're doing is comparing the proposed intervention to existing practice. And we don't look at the world of, well, what's going to happen without this in terms of what's going to be lost in the way that you're proposing there, Nick. There's no reason that outside of that people might not do it, but within what goes to the committees, that's not done in terms of the benefits lost. Certainly in terms of the financial impact, we do look at that in terms of, well, how much of a drug is going to be used, how many people are going to be treated if this isn't made available, and then that's compared with, well, what's going to happen in the world with this drug. So you could get at that indirectly, but not in the way that I think you might be proposing, Nick, which is, what are we losing by not making this available, which I think is your question. So it's not enumerated in exactly that way that you're proposing, Nick. You could back generate it, but I don't think it's the way that you're proposing that it'd be thought about.
Did you want to add anything to that, Sally?
I need to say, I know this is often raised, but it brings about some other complexities in thinking about how we would measure this across various systems. So it's a great question and so complex, but yes.
There's another question from Nick. Thanks, Nick, for all the questions. They're excellent. And Nick has said, Sally and Richard, as a patient advocate for a newly funded clinical trial, how can I help ensure that the best practice in terms of health economics are embedded in the design from the outset, co-design? I'm asking this with a view to participants, our community, being able to access drugs, new and existing, as well as tests, etc., being able to smoothly and easily go through PBAC and MSAC post-clinical trial, as well as potentially aiding justifying access to further ongoing funding and fulfilling unmet needs. That's such an excellent question. Sally, will I throw that to you first?
Yeah, it is an excellent question and an excellent point. And I think it would be, for a lot of health economists, they would say, yes, you need to ensure that it is captured at the outset. And it's unfortunate that often in clinical trials, it's costs are like the forgotten, you're halfway through the clinical trial and you think, yes, it would be good to capture these. Richard might have some other comments, but I would just say, go ahead and advocate and say, yes, we want to have these costs captured, and work out what it is that you think is important to capture in the trial, because it is very important, because you will have that data then that can feed into the process.
Thanks, Sally. I'm going to put on my CREST hat. So CREST is the Cancer Research Economics Support Team. And what we do in CREST is exactly what Nick is talking about here. So our role in CREST is to help the Cancer Australia clinical trials community to embed health economics early on in clinical trials. That's exactly what we do, is to work with clinical trialists to help with their protocols early on to assess, well, should you be incorporating health economics? If you should be, are you doing it? What are you asking the right questions? Are you collecting the right data? So, Nick, I'm not sure if this is a cancer clinical trial. If it is, then I'd be happy to point you in the way of some resources on our CREST website that could help you with that. If it's not, you can still look at our CREST website, because there are some resources on that website that may help you in looking at your particular clinical trial. There are other resources around the world. There are some publications around the world about what should be done alongside a clinical trial, and they may help you in thinking about how to advocate with your particular clinical trialists on what to do. Often the challenge with clinical trialists, and I don't mean to offend anybody on this call, is to get them to see that there is more beyond the clinical question, and that actually addressing that question of how you're going to change practice at the end is really critical. So yes, the science is lovely and fantastic, but unless you can change practice with your answer at the end, why have you done it? So I think it's a really important question to pose to clinicians, and I'd be happy, Nick, to send any resources your way.
Oh, thank you, Richard, because I think there's a real interest in resources and learning from those groups who have been able to do that work. So that would be wonderful. I'm sure there's other people on this chat who would be interested in those as well. My next question is coming from David Hurt, who says he's ex-industry and now a general advocate and consultant. And David has said, is it time to formalise the sponsor's submission with a formalised patient impact statement with a more formalised structure? And he's also said that the current system is frustrating, where indirect costs are ignored, discounts of harm and benefit within the PPAC process is not aligned with other discount rates across government. Is there anything from your experience? I know, Sally, you're across in the consumer evidence unit, and Richard, you're at SHEAR. Is there anything you can say in response to that?
I might just comment on the patient impact statement, because maybe I'm a bit off tangent here, but we have done some pilots thinking about how can there be more information delivered to patients in PBAC about a sponsor submission in lay language, to perhaps give a little bit more information to sort of raise that point that Richard made about asymmetry of information, which will then help with the inputs. I don't know about having a standardized patient impact statement. We have raised this previously. People like to do their own type of information, but definitely provide more guidance, I think. And that's something that we are working on.
Yeah, so if I could touch on the indirect cost issue, I mean, this is a really interesting one. And I hear your frustration, David. Having been in industry myself, I felt those frustrations many times. I think the question is not one of these being ignored, but it's one of ensuring that they are appropriately measured appropriately and included in the right way. So we see that from time to time they are incorporated in PBAC submissions, but we have to ensure that the way that they are incorporated is as much as possible standardized, and that they can look at the ISA with and without these costs, because there are so many issues in how we might measure an indirect cost or something like productivity. The committees need to have some certainty or have some understanding about how much impact those costs are having on the cost effectiveness number. And the only way to be able to do that is to see the number with and without those costs. So it's not a case of them being ignored per se, but it's a case of being able to see the numbers with and without them. And for researchers, it's about being very explicit in how these things are being measured and assessed. And I think that transparency is highly, highly critical. And I'm not saying people haven't been transparent. Please don't assume that that's what I'm saying. It's not. But I'm just saying we need to have a kind of best practice in making sure that everything is very transparent.
Another question we often get asked at Patient Voice Initiative is, if a new drug is exceptionally expensive, will anything get it across the line? And I think there was a lot in your presentations today to answer that, but I just wondered if you could speak to that issue, because we often hear from patients, well, it didn't get through because it was too expensive. And is it solely that, or is it more complicated than that?
Good question. I'm going to be the loudmouth and start with a question. So should we be asking why it's so expensive? So I'm just going to pose that as an open question. And then, is there something that can get it through? I think I tried to make this point that the committees look at many things beyond just the cost effectiveness and beyond the expense. I don't believe that there's any one factor that, if you look at all the drugs that you could point to and say, yes, this always gets them through when they're high cost drugs, or this means that they will always fall over. It really is a case by case basis, I think. There was a paper by Anthony Harris, it's old now, probably 2007, where they looked at these factors. They did find a slight difference for some indications, but it wasn't anything highly meaningful. So I think it's difficult to say that there are particular factors that mean a high cost drug will get through or not. It's really a case by case basis. I don't know that I gave anybody a satisfying answer there, sorry.
It was good to think of the questions to ask. Thanks, Richard. Sally, did you want to attempt that one?
I think it's touching on that point, because I've heard this before about people thinking that it's the consumer evidence that's making or breaking the evidence, the submission, of whether it's being approved or reimbursed or not. And I'd sort of echo what Richard's saying around there are other factors that are going into play, and for people to understand that it's great to provide consumer input, and good quality input's very important, but that's only one sort of element, and there are other considerations going on. But it's not so much the factor that we have. If it's high cost, it won't get through, because we don't have that threshold that we do in that there are in other countries.
Oh, thank you. I think sorry,
and
Richard?
I did. Sorry, and I was going to say I did post that paper in the chat. So I mentioned a paper in the chat which compared outcomes from NICE with outcomes in Australia, based on the fact that NICE has a threshold and we don't. So for those who are interested, that's in the chat, the actual paper.
Sorry, I just lost my microphone for a moment there, Richard. Apologies, I was fiddling with the screen. Thank you, and thank you very much for those links as well, which have been really helpful. And I think actually, Sally, that comment's a really good one to reflect on as we come to the end, because we always talk about the value of consumer input, but we also always recognise that getting involved is a stressful and a demanding experience, and it's something people can be reflective about whether they want to become involved, and also not feeling that that your consumer input is going to be the make it or break it, that you haven't failed if you didn't get the outcome you wanted, that it's always that combination of the way the evidence comes together, and we're really keen that people somehow manage to keep that in mind, despite the huge stake that you have in this process as patients. And so with that, I'd really love to thank Richard and Sally for what's been a really engaging session. We will, like all our other webinars, we will put the subtitles on them, and we should have last week's uncertainties one up early next week, and then probably the following week this one will go up on our YouTube channel. And it's a great chance to just replay them and catch those bits that you missed, because there's a lot of information, I think, in these webinars, and we did ask Sally and Richard to cram an enormous amount within their 20-minute slots this morning. So thank you so much, Richard and Sally, and thank you, Jessica, for welcoming us and keeping us on track again through these sessions, and thank you all for joining with your questions. We look forward to putting together another series of webinars, and we love to know the topics that you're interested in. Perhaps some of the topics that we touched on this year you'd like to dive into even deeper, and we're certainly up for that as well. So thank you again to our speakers, and thank you very much for joining us today.
Thanks, Anne. Thanks, everybody.
Thank you.
Bye now.